So today I'll be discussing on the risk factors for recurrent disc herniation. So let's begin. Now we know that disc herniation with a symptom-free interval post-discectomy of at least 6 months with same side and same level herniation again classifies as recurrent disc herniation by definition. The recurrence rate has been reported in literature between 2 to 27%. Extremely frustrating problem, not only for the patients but for the surgeons as well. And some literature reports show the reoperation rates of 15 to 25% within the first 2 years post-discectomy. Now, in order to study what factors, let us go through the journey in literature. Majority of the work which was done in mid-1990s focused on individual patient factors, including the level of disc degeneration, age, smoking, gender. The next 10 years or so, literature focused more on radiologically identifiable factors, including the level of disc degeneration, the disc height index, as well as the segmental range of motion. And in the last 5 years, currently artificial intelligence, machine learning have been deployed to accurately predict rates of recurrent disc herniation. We also have found nomograms to help us with the prediction rates. Amongst the individual factors, smoking has to be the most widely studied factor. Miwa et al. Found that smokers are 3.5 times more at risk versus non-smokers. A plausible explanation are the toxic substances causing vasoconstriction and impairing the post-operative wound healing. Hence, cessation of smoking is widely practiced. However, point to note is we still don't know how much time is required for the risk in smokers to decrease to non-smokers when we consider recurrent disc herniation. Meredith et al. Found that patients with a BMI of more than 30 are 12 times more likely to develop recurrent disc herniation. Hence, obesity is also a major risk factor and a lot of literature supporting that. But we have some data coming from the SPORT trial which shows that BMI may not be as important as previously thought. So the verdict is still out there. Other non-modifiable factors are the patient's age. Now, older literature found that older patients are more at risk for recurrent disc herniation and possibly related to the impairment of repair capabilities. But again, the SPORT data found that even younger patients who have a very active lifestyle may also land up with higher chances of recurrent disc herniation. Coming to the intraoperative factors, it's a balance between how much disc we remove and how little disc we remove. Megarth et al. Found that limited discectomies, though leads to faster recovery, might be associated with higher chance of recurrent disc herniation. And on the other end of the spectrum, too aggressive discectomy may lead to significant amount of disc material being taken out and subsequent instability. Amongst the type of disc herniation, protrusion and fragmented herniations with large annular defect have been known to have higher chances of recurrent disc herniation versus the other varieties. The radiological parameters widely studied are the amount of disc degeneration, the disc height index, the segmental range of movements, as well as the associated lumbar lordosis and facet joint degeneration. Now, we routinely follow the Fuhrman's grading in order to know the level of disc degeneration, with grade 1 being normal disc and grade 5 means severely degenerated disc. Literature shows that grade 3 and 4, that is not too bad, not too good, as with regards to the disc degeneration, are more likely to be associated with recurrent disc herniation. The disc degeneration grade, along with the modic changes, that is the end plate changes, may be associated with higher chances of recurrent disc herniation. And we have some data to support that as well. Now coming to the disc height index, so it is a quantifying way to know what is the amount of material in the disc. It has been found that larger disc heights preoperatively may be associated with higher chances of recurrent disc herniation, and a possible explanation is a larger disc height preoperatively may lead to more amount of disc material being taken out and subsequently leading to segmental increased stability. Lumbar lordosis, pelvic incidence mismatch, as well as lower lumbar lordosis may lead to suboptimal sagittal alignment and distribution of weight, and lead to aggravated disc degeneration as well as facet joint degeneration. So where do we stand currently? So we have multivariate analysis using artificial intelligence which have been used to find predictive factors, and also nomograms which have been devised. Harada et al. Studied 30 such factors, and they employed machine learning and came out with 7 factors most highly predictive of recurrent disc herniation. They studied almost 2,600 patients over a course of 14 years, and they found that VAS leg score, oswestry disability index, lower lumbar lordosis, high BMI, coronal angulation, duration of symptoms, and age in decreasing order of importance to be associated with higher chances of recurrent disc herniation. He et al. Published a nomogram in 2023. They found 5 parameters and gave pointers to each parameter. They found this nomogram to be highly predictive, as we can see by the area under the curve, which is 0.868, which means fairly accurate predictive from this nomogram. So to conclude, multiple factors are responsible for recurrent disc herniation. As surgeons, it is important to identify and have a clear communication with the patients, and it may also be a premise for selective use of various approaches aimed at recurrence.